G'day, I'm Tony Lembke. I'm a GP in Austenville in far north coast of New South Wales. Austenville's up near Byron Bay, above in the hinterland above the town of Ballina. Ballina, as you know, is most famous as a fishing village, and they've erected a huge monument to celebrate their major industry, and the big prawn is something you need to visit when you're in Ballina. If you're in Austenville, not to be outdone, the Chamber of Commerce have erected their own monument to the major demographic and industry in our town. So this is the main street of Austenville. If you come soon, you may have missed the Austenville show. There's Bob Wilson and Chook Fowler preparing for the show, but next month it's time for the premier event on the Austenville calendar, the Austenville Gopher Fest, when our community get out and celebrate their skills in riding gophers. Don't miss it. All right, I have the opportunity to serve the Austenville community through the Austenville Clinic, where I work with my colleagues. I've been there for 25 years now. I've also had the opportunity to be chair of the North Coast Primary Health Network, which gives me some protected time to think about systems and the health system in general. And I'm most proud of having been Sydney Uni Donkey Kong Medical Society champion in 1983. So what do we want from our healthcare system? How can we design the healthcare system to best achieve those aims? Now, the WHO says the healthcare system aims to promote, restore, maintain health by making sure that every person and their family can access the resources and care that they need when and where they need it. This mission for the healthcare system is sometimes now expressed as the quadruple aim, which is 1, how do we improve health outcomes for the patients we serve? 2, how do we improve the experience of receiving care for those patients? 3, how do we improve the experience of clinicians in delivering that care? And 4 is, how do we live a better value or improve the bottom line or improve the cost of the system? That's the quadruple aim. It's expressed differently everywhere you read it, but they're the 4 key principles: how to improve health outcomes, improve the experience of care for patients and clinicians, and improve value. When we're trying to solve that, we need to be pretty clear about who we're caring for. And the Austenville community reflects the Australian community in that increasingly we're caring for people who are older and people with more complex and chronic conditions. We know that in my practice about 50% of the patients have multiple comorbidities, and we know that the healthcare dollar is going to fall off the fiscal cliff anytime soon if we don't do something to bend the costs of caring for all those people with multimorbidities. So it's one of the aims of the healthcare system. Now, it's important that we get this right. This is Mick Roberts, who was CEO of the Aboriginal Medical Service in Casino, and he spoke at one of the early collaborative meetings I attended, and he said, it's very serious. He said, I had 7 brothers or sisters. 5 of those have already passed away. In my community, I'm considered an elder, and I'm 55. Of my colleagues I went to preschool with, 72% of those have already passed away. We need to work out how to get it right, how to have a health system that delivers good health outcomes to people with multimorbidities and chronic conditions, as well as to other people with acute medical conditions, and maintaining routine health. It's really important that we get it right. Mick now owns the Gonna Wannabe Cafe in South Lismore. If you're down there, you can call in and say hello to Mick and hear his stories for himself. So one of the models that we might consider to solve this problem of making a health system that works to allow everyone in the community and their families and carers to access the healthcare that they need is by looking at what we call a person-centred health system. And a person-centred health system is able to look after our patients who are crying out for a health system that delivers the sort of care that they need. It enables clinicians to work in an environment that allows them to use their skills and deliver the sort of care that they want to deliver to their patients. And by bending the cost curve, it can make our funders happier. And at the centre of a person-centred health system, of course, each patient or person and their families and their carers. And unashamedly, we focus north for reasons that we'll come back to. The real work happens in health. The real work in health happens in a patient's home, supported by their families and carers. It doesn't matter so much what we do in the small number of interventions we have, it's what patients do in their home, what they do with their lifestyle, where they go for a walk, what they eat, what they smoke, what their relationships are like, what their employment's like, what their other social supports and their networks are like. Makes most of the difference in health, and we'll talk about that. Now, the international evidence is that patients do better if they have a long-term relationship with a particular primary care provider and that primary care provider is supported by a primary care team. And in Australia, the primary care providers taking on this role, by far the majority of them are general practitioners. Sometimes remote area nurses can fill that role. That's called the medical home. General practitioners supported by other general practitioners, and increasingly by new roles, practice managers, receptionists, practice nurses working as care coordinators or chronic care managers or patient assistance managers. Pharmacists have started to work in many general practices, sometimes specialist services, and more behaviouralists, people like diabetic educators and dietitians and exercise physiologists, working as one team in a long-term relationship with each of the people they care for as part of a medical home. Now, not all services can or should be provided within the medical home under that one roof, and the medical home team acts as a gateway to other services that some patients will require in the community, making sure they can access the care that they need, and this includes allied health providers, physiotherapists, psychologists, pharmacists, diagnostic imagers, medical specialists, and other services such as Meals on Wheels and nursing in the home and other care that's provided to the patients in what we call the medical community or the medical neighbourhood. And of course, some patients for some periods of their care will require the more specialised services that are required in secondary and tertiary hospitals, completing our medical neighbourhood. Now, in defining a person-centred health system, one of the keys is that each person in their family should be able to access the care team that they need, that this team should be of high quality and they should act in a joined-up way. Care should be experienced as integrated. So forming an integrated care team for some people only involves the general practitioner. They're having preventative health, they're keeping well, they're managing themselves well at home, and the team is small. For some patients, their medical conditions require a larger team, which may include other behaviouralists and practice nurses working as care coordinators, medical specialists working in the community, and that becomes their core integrated care team. For a brief period of time, patients require care delivered in hospitals. Ideally, the community team, the core team, the care that's consistent longitudinally over time, including the primary care provider, the GP, have in-reach into that hospital to influence the care and to be sure that when the patient is discharged from hospital, that the community is ready to receive them and have the skills in place. And then the team contracts as the patient's medical conditions improve or the level of care changes over time. Instead of being transferred from one team to another team, as we might see in some systems or in some hospitals, you can come in with chest pain, be seen by the ED team, transferred to the cardiology team. The cardiology team decide that it's not cardiac, so you're transferred to the gastroenterology team. They decide that it's not your GIT, so you're transferred to the geriatrics team, and then they don't know what's wrong, or they may know what's wrong, and then you're discharged back somewhere out there in the community. Who knows what happens then. Ideally, the patient would experience a core team that would expand and contract in the skills and services it can provide over time, but there'd be some continuity and care and longitudinal relationships over time to support that. So all the layers of the health systems are important. The aim of a person-centered health system is to strengthen each layer, so that less people filter out to the outer layers to receive care, keeping those specialist layers and those hospital layers free for people when they really need them. A service that focuses resources in the centre of the system as care is delivered closer to the patient in their home. It is patient preferred. Nobody really wants to be in hospital. People prefer to be at home. It is more effective to deliver care closer to the patient earlier in the disease process. It is certainly less expensive. Did you know that it is cheaper to see your general practitioner once a week for a whole year, 52 times, than it is to be admitted to hospital for one day? For one day. So the more services we can deliver in the community closer to the patient's home, the more efficient it is, the less expensive it is. Closer to the centre of the circle, it is more whole person care, more comprehensive care, outer layers of the circle more disease specific, and therefore closer to the centre of the circle more generalist, the outer layers of the circle more specialised. There's a role for all parts of the health system. The outer layers should support the inner layers to build their capacity to look after people more effectively and to keep them as much as possible within those inner layers, to free up the outer, more specialised layers to see those patients who really need those care. Everybody working at the top of their licence in a team-based approach. Now, why do we know that this system works built on primary care? And we know from the work of Professor Barbara Steinfeld and many, many others that in chronic disease management in particular, the most efficient and effective health systems are not produced, better outcomes are not produced by more investment in hospitals, more investment in specialised care, more investment in diagnostic imaging, more invested in pharmaceutics. Better outcomes are produced by more investment and better delivery of primary care services. In fact, the recent studies show that if we want to increase hospital admissions, if we want more and more people in hospital, the way to do that is to build more hospital beds. That's number one. The second way is to build more disease-specific teams operating out of hospital that focus on special diseases and coordinate care from the hospital level. That's a way of bringing more people into hospital. And the third way is to draw people away from their normal primary care providers, from their normal general practice, and deliver more services near the hospital. So if we want to increase the cost to our society, have less good outcomes, and to improve the number of hospital admissions, we should build more hospital beds, have more disease-specific clinics in the hospital, and draw people more and more away from their general practitioner. Instead, we should, of course, be investing in putting resources as part of the medical home team and delivering them in the community where it's patient preferred, more effective and more efficient. So why is primary care investment, why does it produce better outcomes? And part of the reason is this: if we were to look at, and studies have looked at, what makes a difference to a patient's health outcome, what makes a difference to their health outcome, about 11% of that can be attributed to the medical care that they receive. Only 11%. And the rest is due to a combination of other factors, as outlined here. Now, if we could, we're responsible for that medical care. If we could take more and make more and more difference to this other section, the individual behaviour section, then we're getting much better bang for our buck. And the individual behaviour section, of course, is what happens in the patient's home. And so we need, as doctors and as people working primary care, to be teachers, to be coaches, to be cheerleaders, to assist patients to live in ways that optimise their health. So the real work in chronic disease management is done by our patients and their families. And I'm indebted to Doug Eby and the South Central Foundation for this slide that they have prepared, that we act in health as if all medicine is like the acute medical system. So if I was to walk out of my home today and get run over, which has been unlikely out here, but run over by a bus, and unconscious, my outcome is determined by the health system entirely, nothing to do with me. It depends how quickly the ambulance can get there, how effective they are in ED, the skills they have in ICU. My outcome is dependent on the system. And we act like all health is like that what matters is what the doctors do or the nurses do. But in fact, for complex and chronic conditions, for long-term medical conditions, the outcome is really determined by the patients and their family. And so they're the ones that make the difference, they're the ones in control. So when acuity is high, its outcome depends on the system. When acuity is low, it depends on the patient and their family, which is why investment in primary care make all the difference. Now, the patient-centred medical home might be defined, the medical home is a concept that's talked about a lot, and we might define it as a general practice or Aboriginal medical service that a patient chooses to be accountable for their ongoing medical care. And the literature suggests that there are 5 key attributes that determine the effectiveness of a medical home. If your medical home is high performing, it will be achieving person-centred care that's accessible, comprehensive, coordinated, and has a focus on quality and safety. So you can see that the medical home is another term perhaps for a high quality, high functioning general practice. And we know that in Australia all medical homes are either general practice or Aboriginal medical services, but not all general practices and Aboriginal medical services are acting as medical homes. The term patient-centred medical home was developed and defined in the United States of America to describe what for them was a new approach to comprehensive primary care. The model of care it represents has developed significant momentum in the USA and subsequently in Australia, and is now cited often in policy documents by federal and state governments. There is a large and growing body of research that demonstrates the effectiveness and efficiency of the model. In a medical home, a patient has a long-term relationship with a particular general practitioner, supported by a high-functioning practice team, and the rest of the health system wraps around that relationship. Although a person-centred medical home can be a process of accreditation, as it increasingly is in the USA, we prefer to see it as a process of quality improvement. So, a general practice that aspires to provide the highest quality of care to its patients in a comprehensive, accessible, coordinated way, delivering care that's both person-centred and focused on quality and safety, is a medical home in the Australian context. We might describe each of these attributes of a medical home in a bit more detail. Person-centred care. Recognise that we are the most important part of the care team and that we are ultimately responsible for our overall health and wellness. So medical home recognises the real work in improving health is done by the patient and their families, as we have discussed. There is a focus on empowering people to better manage their own health to the extent that they can. We partner with patients, carers and families to ensure cultural preferences and values are respected. Patients receive education support for shared decision making. Patients have the opportunity to participate in the design of the care systems in a medical home. Comprehensive and continuous care. Provide or help us get the healthcare information and services we need. The medical home provides whole person care, so it's responsible for the full range of each person's physical and mental health care needs, including prevention and wellness, acute care, and the management of long care conditions. It either provides the care itself or it makes sure that people can access the most appropriate provider for all their health care needs. So it adopts a team-based approach that includes providers with a full range of skills, and that includes care management and coordination. It also provides continuous care. Be our partner in time in caring for us. Care in the medical home is continuous. Each patient has an ongoing relationship with a particular GP and the medical home team. The team-based approach allows for continuous care. So every staff member in a patient-centred medical home is expected to have an independent relationship with patients and families on their team, of which patients are the most important member, and they help design workflows in the practice. And the medical home recognises the whole population for whom it cares, and it's proactive in recognising people who are missing out on care, especially those from disadvantaged groups. So it reaches out to support patients who need help with a variety of needs, social, emotional, financial and beyond. Medical home provides coordinated care. Help us navigate the healthcare system to get the care we need in a safe and timely way. So the medical home accepts accountability for a patient's care even when that person is not standing in front of them, and it acts as a gateway to the rest of the health system, which it assists patients to navigate. So sometimes this includes hospital and inpatient care, which it arranges and coordinates. It tries to ensure that each patient receives the best possible care from all members of their care team. It's also important to note that a medical home is a curator of each person's medical history and maintains accurate clinical records, that they're custodians of their patient stories. So it works to ensure each patient experiences integrated or joined up healthcare in which there's consistency of information between all team members with clear goals, roles and communication pathways, and it advocates for its patients by promoting the person-centred health system that we've talked about. Accessible care. Healthcare team, be there when I need you. So in a medical home, patients access care for their acute or routine needs when they require it. Arrangements are clear for urgent out-of-hours care. The medical home is also proactive in managing chronic conditions. So in a medical home, access is more than just coming in for a visit. It also allows people to answer questions over the phone or email when a visit's not necessary. and in many patient-centred medical homes now, telemedicine and home visits are being used to provide timely and convenient care to patients. And other asynchronous tools like text messaging and social media are used to encourage patients to keep up to date on important health considerations and to be aware of upcoming appointments. And finally, a medical home is a focus on quality and safety. Take responsibility for making sure we receive the best and safest possible healthcare. So medical homes develop systems-based approaches that make sure each patient receives the highest quality care, and they implement systems to improve patient safety. A medical home will engage all staff to identify and follow patient population and disease-specific needs, and it uses continuous quality improvement processes to drive performance to the highest levels. Two other points to note. There are many practices in Aboriginal medical service in Australia that are already aspiring to provide the highest quality, comprehensive, accessible, coordinated care for their patients and are focusing on quality and safety, so they're already functioning as medical homes for the communities that they serve. Our challenge is to make what's possible practice, usual practice, and also to incentivise high quality, high performing general practice. The second point to note, therefore, is that on this line, the Federal Department of Health is currently trialling a healthcare homes trial, which is based on recommendations made in the Primary Healthcare Advisory Group report called Better Outcomes for People with Chronic and Complex Health Conditions from 2016. So in the healthcare homes trial, the PCMH model is being tested, in which patients can choose to enrol in a particular practice, and they will receive, the practice will receive block funding for the chronic disease management of those patients enrolled in the trial. Practices are also being trained in the fundamental attributes of the medical home that we've discussed. So this is a test of a new funding model that may support, is designed to support, more comprehensive, team-based, proactive, systematic chronic disease management. So that trial is being extensively evaluated, and we await with interest the reports from that. Finally, I want to say a little bit more about what I think we mean by person-centeredness or patient-centeredness. We've talked quite a lot about that in the person-centered health system and the person-centered medical home. Now, if this talk that we're having was student-centered, I would know that it was effective, because the students who listened to the talk and participated would change something in their behaviour. So they would change something in the way they use their hands, their feet or their mouth after the lecture that they didn't do before. So we're looking for behavioural change to measure the effectiveness of this lecture. If this talk is intended to produce improved healthcare outcomes, then we need to look for changes in our patients that we're serving, such that they do something different with their hands, their feet or their mouth as a result of the healthcare services that they deliver. So person-centered healthcare is focusing on individual patients and making sure that they can do something different that gives them a richer or more meaningful life. I consider a very behavioural approach. Unless our patients are doing something in their behaviour with their hands, feet or mouth that gives them a richer or more meaningful life, then we haven't delivered value. So when we talk about person-centeredness, we're talking about, as we design services, focusing north on the needs of individual patients. As my colleague Ralph Autumn says, focus on the patient. Everything else is a proxy measure. So let's say person-centeredness, aspiring to improve our patients' lives, to make them richer and more meaningful. And as we design services, we should look at every step we're designing to see whether it's contributing to this aim, and our measures, as far as possible, should be measuring changes in patients' behaviour that reflect that their lives are improving or better than they would otherwise be from the healthcare that we delivered. So we've got to focus on the patients to whom we're providing the service, and that's the point of the person-centered health system and discussions about that.